Broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to today's webinar. This is the cardiac surgery among older adults living with frailty towards optimal decision making. Today we have Dr. Greg Hirsch and Ryan Gaynor joining us from the Nova Scotia Health Authority. Just a couple of announcements before we get started. I will answer as many questions as possible during the webinar, and I am Amanda Lorbergs, the Manager of Research and KT here at CFN. We'll have a survey at the end of this webinar so that it will pop up on your screen. Please let us know how we did and how we can improve in the future. And we have our next webinar scheduled for the end of the month on Wednesday. I am corrected. It's actually on Thursday, the February 28th at noon. And this will be with Doctors John Hurdes and George Heckman from the University of Waterloo. A couple of announcements from CFN. The first is to please submit your innovations for an opportunity to be highlighted at the National Conference on Frailty, which is coming up in September of 2019 on the 26th and 27th. CFN is also working with CFHI, the Canadian Foundation for Healthcare Improvement, to highlight the top 5 showcase winners from last year's conference. So if you'd like more information about that, you can go to the website listed here below. And now I will introduce our speakers for today. They are Dr. Hirsch, who's a professor of surgery and director of research in the Department of Surgery at Dalhousie University. He's also a staff surgeon at the Queen Elizabeth II Health Sciences Center. And joining him is Ryan Gaynor, who is a research associate who joined the Division of Cardiac Surgery at Nova Scotia Health Authority in 2010 and is currently a master's student in clinical epidemiology, also at Dalhousie. So I will hand it over to you now, Greg and Ryan.
Thank you. And we're just getting our slides up. Good. So a slide showing, right?
Yes, everything is set to go. Go ahead.
Okay, so thanks very much. Thanks for the opportunity. We'll go through a fair bit of the work that we've been doing over the past few years and then leave some room, I hope, for some productive discussion. So as a practicing cardiac surgeon, it's easy to see the change in the types of patients that are referred to us, and we'll show you some quantification of that impression. But what one notices amongst your patients as they age, and particularly those that are frail, we see a fair bit of decisional regret. And I think that's the impetus for a heart surgeon to look more carefully at how decisions are taken to undergo cardiac surgery in a vulnerable population. So in today's talk, we're going to just go over aging and frailty trends in cardiac surgery and their impact on outcomes, and a review of our efforts to establish shared decision-making to improve the quality of decision-making in those vulnerable patients, and then to talk about the more recent work that is the funding that we've received from CFN, most recently trying to improve our screening for frailty and what the impacts of that screening have been on outcomes. So this just quantifies what I observed sort of living the life. This is 10 years of data from 2000-2010, which we published in the Canadian Journal of Cardiology. And what I draw your attention to is the fact that the proportion of octogenarians has steadily been increasing in the patients that we're looking at. And there's been a trend in the reduction in younger patients. And most importantly, this is I'm not sure how many people are familiar with Katz, probably most, but it's a measure of activities of daily living. It's a pretty crude measure of frailty. If you're Katz frail, you're pretty frail. We added to that dementia and mobility requiring a walker or worse. This is retrospective data from our cardiac surgery outcomes database rather than prospectively collected. But you'll see a rather dramatic rise in recent years, and now it's as high as 15% of patients referred to us for cardiac surgery are frail by one of these criteria. And of course, frailty would be positively associated with age, and we see the shift over time. Nevertheless, of course, as everyone who'd probably be tuning into a CFN webinar is aware, frailty and biological age are not the same, and frailty, which I won't spend a lot of time defining, a cumulative set of defects that just reduces an organism's resilience, so that if there's an insult like a coronary bypass operation or an acute myocardial infarction, the recovery isn't full. One gets into what Laurie Mallory here with the geriatrics group and Paige Morehouse would refer to as the cycle of frailty, where every major hit returns you just a slightly frailer state. So our clinical successes are actually rendering the population increasingly frail. It's really sort of no getting around it. And your recovery may leave you dependent. And I think it's this consideration that we think is very important for patients to take into consideration. Again, age is chronological age and biological age are different, and any tools we have at our disposal to distinguish those two would be helpful in terms of both recommending what patients might have done and to elicit patient preferences about what should be done. So somehow we were the first group to ever publish on the impact of frailty on cardiac surgery outcomes. We used, as I described above, Katz plus mobility dementia. And it had an impact on hospital mortality with an odds ratio of 1.8 with an interquartile range of 1 to 3. But more provocatively, I think, and potentially more importantly to this patient population, the risk for prolonged institutional care was an odds ratio of 6.4. Now, this is a bit of a soft definition and a weakness of the initial work, because that just meant the patient was not well enough to go directly home. We think that's related to a more chronic loss of independence, but we're in the midst of studies to actually nail that down. Suffice to say, anybody who can go home from our center does go home, and so this is a group of patients who are at least in for a prolonged recovery, if not ultimate loss of independence, and it's a high odds ratio. And these are just the same. It's just the same study showing the logistic regression results with the odds ratio of 1.8 for frailty, and demonstrating statistically that it's independent of age. And it also has a longer term effect. This is medium term survival, showing the frail patients who do get out of hospital enjoy less survival. And this is that logistic regression for discharge to an institution rather than home, showing that odds ratio of 6.3. So together, we felt that the changing face of the cardiac surgery patient, the increasing prevalence of frailty to 15% using a crude measure, gave us unprecedented equipoise between cardiac surgery and medical therapy, and called for real input from patients around their preferences and trade-offs. And an example would be an 80-year-old with coronary disease and tight aortic stenosis who's symptomatic but can get around the house, just can't walk a level block without a break, still living independently, still looks after the school-age children until their parents come home for 2 hours in the same household, for example. So they have a current quality of life. Is it acceptable? The risk of intervention will increase over time, so there's a time trade-off. We could intervene now and preserve what you have, possibly improve it, but you might also lose independence. And if we could put some numbers to that and get patients to comprehend it, we thought that would be a very worthwhile intervention. I'm going to turn it over to Ryan, who's our master's student, to talk about our decision-making efforts from there.
Thanks, Dr. Hirsch, and good afternoon, everyone. So as Dr. Hirsch said, with this changing demographic and our acknowledgement of increasing frailty over time, it sort of behooved us to look a little deeper in terms of the consenting process around cardiac surgery and the decision-making process that patients who are older, potentially frail, go through. Some of this was spurred on by the literature, and particularly a seminal document Crossing the Quality Chasm, the Institute of Medicine put out in 2001, which took to 6 aims of really overfacing the quality of programs and care, and one of the particular issues that they centered on was patient-centered care, and this really spoke to moving away from maybe that historical paternalistic approach of medicine towards something that really provided a more patient-centric approach where care is customized according to patient needs and values, and the system is set up in such a way to sort of help respond to and can respond to individual patient choices and preferences. It speaks to having more autonomy for a patient, where it's not solely the patient sort of being only the control, but acknowledging that they are an expert in their own personal set of values and preferences for care, and the physician and care team are still housing their expertise, clinical expertise and judgment. And between the two of them, that together they sort of come to a decision that bores out the acknowledgement of the sort of biological issues, but also a clear discussion of treatments, options, benefits, and risks. So while we were looking at the literature for this, part of why it created this impetus for understanding how to best consent patients was look at what's currently out there and what the current consent practice is like in surgery. And what we've seen is the majority of studies really demonstrate woeful comprehension of acknowledgement of procedure or its alternatives, and yet worryingly most patients are satisfied. So a few of these papers at COD showed that only 50% of patients could recall something as basic as the surgeon's name, less than 50% felt in control, and yet 80% felt satisfied. So this concept of patient satisfaction alone being an indicator of successful consent may not necessarily be accurate. As well, Brezzi showed only 10% of patients could restate what was explained to them at the initial consultation, and at the same token, 80% saying that the information they received was very good. A few more specifically looking at cardiac surgery and comprehension in informed consent, where only 40% knew general mortality risk, 65% couldn't name a complication of their surgery, and up to 15 couldn't name the surgeon that was performing the surgery. So ultimately, considering the potential issues for an at-risk population, a vulnerable population, and having this lack of clarity in the consent process really reinforced us to look at how we could maybe improve this process for such vulnerable population. So there's 2 things that came out of quite a bit of work through Victor Montori, Glenn Elwyn in Rochester, and there's a group in Ottawa, Annette O'Connor, who have been looking and doing a lot of work on shared decision making and decision aid. So I'll speak a little bit to what each of these are and how we've implemented them into our group for patients who are older and potentially frail, and how that has ultimately helped to shape the decision-making process in our institution. So why do we want to do this thing called shared decision-making? Again, it comes out of that call from the Institute of Medicine for Patient-Centered Care, where a formalized process really of activating the patient and engaging the patient as sort of equal partner in being in control of their medical care, where information is a two-way street and not without the patient, but including them as best as possible. And again, while care team is experts in determining best evidence care plans, the patient's really the expert in their own values and preferences. It's not really the surgeon or the care team who's going to be able to elicit those things or assume them, unless the patient is activated to sort of bring that information to the floor. And these values and preferences need to be incorporated in determining the care plan. So again, I think I spoke about this a little bit, but ultimately a collaborative process, shared decision-making between care team and patient and the family that arrives at a care plan based on best evidence as well as patient preferences. It honors that the provider is the expert in evidence-based care and the patient's the expert in values and preferences. So we did a pilot study at the sort of initial point of identifying the constraints or the difficulties with consent to really prepare our center to see what the issues were, and it seemed the best approach, the best medium to do that was a qualitative study for both patient and provider perspectives towards key consent topics. So we ran several focus groups, and these were patients with coronary artery bypass grafts, valve surgeries, or a combination of both, over 70, and then separate groups of nurses, IMCU and ICU nurses, surgeons, anesthesiologists, and cardiac intensivists. And during these groups, we created these individualized trial mock-up decision aids that were, I'll show in the next few slides, but just a medium to discuss what the current consent process is like and what patients' experiences of it was and providers' experience, and what we could do, if anything, to sort of improve that process. We used in vivo 9 software to organize code and develop comprehensive themes, and thematic content analysis with the constant comparative approach was used for the methodology. So just to give a little background, this is quotes from some of those key themes. We can put up the published paper from the Medical Decision-Making Journal, but ultimately these are just to point to some of the key quotes that we that would come up again and again in different frames. And you can see up at the top right, a patient would say, "You're just part of the assembly line. You might slow the assembly line down, stall it a little bit or something." And that really did generate from multiple focus groups the sense of you're on a roller coaster, and your physician and your surgeon have sort of identified this care path, and you don't want to derail it in any way or slow them down, and a relative deference to the decision-making process to the surgeon and to the care planning team. On the bottom left, this idea from the cardiac care team in the red, we need to have ongoing conversations about what our care plan is, about where we are and how this relates to patient expectations. And then lastly, on the bottom right, not uncommon for them to say, "I don't have a choice," and you say, "So are you ready to go ahead?" And the patient again sort of reaffirms this sense that there's no real choice. I don't have a choice when it comes to deciding about the decision to have surgery or not. And lastly, just a few others that I think are particularly poignant. In the top right, it would be nice if someone had given me a little more communication. It doesn't have to be the surgeon, just someone who knows. So relatively important in these areas that when it comes to that professional deference, there's a communication process where there's such a concern about holding anyone up, and particularly holding up the surgeon that's involved in your care. But if we remove that one rung down or one rung away from the surgeon to nurse practitioner or patient navigator or a decisional coach, that really then can provide the linearity of care to the patient, someone who has some understanding, and it doesn't necessarily have to be the surgeon, but someone who can maybe speak a little bit more to their process, the options, the risks and benefits, and then ultimately be in a position to provide real informed consent. And lastly, the cardiac care team said, and we've heard this over and over again, quote, "If I had known," it had been said to members of the cardiac care team, quote, "If I had known what this was going to be like, I would have never gone through it." So of these groups, there was actually quite a good amount of unison between the patient and provider groups, where both, perhaps not unsurprisingly, they were supportive of adequate time to discuss care preoperatively. So the sense of having whatever medium we use, a decision aid or a decision coach, if that's happening the night before surgery or a day before surgery, that it wouldn't really be enough to adequately influence decision-making at that point, and potentially even comprehension. Again, I'll show this once we have an example of our decision aid up, but this is an example of the groups being supportive of individualized risk assessment. So the idea of not simply a generalized pamphlet, one size fits all, but as a medium, as a way to activate patients, engage patients, is to have some metric, and we can at our institution is identify individualized risk assessment. So of 100 patients like you, 5 will have experienced a stroke, or 5 will experience this risk. And we found that as a pretty powerful approach to really engaging and activating patients and asking questions and getting feedback from them. Range of decisional supports was also an issue. And then this idea, again, of a decisional coach, someone separated from the surgeon, but still largely connected to and intimately connected in the care of the patient, to meet with patients and families prior to surgery, to discuss the things that we know patients are their own best expert in: values, concerns, and questions to facilitate decision making with the care team. So again, some avenues in which we can improve consent. These decision aids are documents that effectively provide more information to patients, but in a very targeted fashion, and identifies particular issue that the patients facing, the treatment options that are available to them, and the relative risks and benefits that are inherent within them. So we ultimately focused on designing a formal shared decision-making approach utilizing a decisional coach with, at the beginning, paper-based individualized decision aids. So I'll show you, I think the best way to present this is maybe what a decision aid, or an example of a decision aid looked like, and more importantly, what an individualized risk decision aid looks like, and that's what we have been able to present to our patient population. So this is an example of what we have generated for every patient that comes in over 65. We're able, if you can see in the middle of that page, this is the individualized profile for that patient, a 66-year-old man with diabetes, hypertension, and triple vessel disease. So identifiable risk factors that we know will influence the individualized risk going forward with their surgery. It gives some information about their particular heart condition, some information about what that is and the biology of it, along with, for particularly this example is for coronary artery disease, what the available treatment choices are at that time, and laying them out in a language that another sort of large issue that we noticed with and is replete in the literature is consent forms, the 17, 18 pagers with content that is maybe at a 12th grade level or university level, where no one, it's very difficult for people at limited health literacy to maybe be activated and ask questions about anything when there's a whole host of information and language that is a bit beyond. So we attempted in this first mock-up to at least present it in a more conversational fashion. And again, this just showed the options for coronary artery bypass graft surgery, angioplasty or PCI, and not having a procedure, but through medical management. So this is one of the important pieces, a crux of the individualized portion of decision aid, is being able to present individualized risk for each patient. So at our institution, we have a Maritime Heart Center database that we've collected pre, intra, and post-operative outcome data and information on every patient that comes in to the Halifax Infirmary, which is a tertiary cardiac care facility serving the entire province of Nova Scotia. So what you can see with these slides, these are called Montori dots, effectively 10 by 10 red and green dots, where of 100 people like you, 3 will not be alive after surgery, 1 will have a stroke after surgery, 1 will be discharged to another institution for continuing care, and 2 will require dialysis after the surgery. I should note as well that our prediction models, our risk predicted models, include the Katz index frailty predictors to establish these, but our subsequent work will be developing content that looks at more subtle degrees of frailty using the frailty assessment of care planning tool by Drs. Morehouse and Mallory to really provide zero in on more accurate risk assessments. So this is an iterative approach, but our first sort of iteration of that was with the Katz content that we had shown earlier. Again, this is a midterm mortality risk at 2 years with surgery, and then an important piece on that latter on the right-hand side is the likelihood of mortality at 2 years with medical management. Previous slides showed that this was red or green, sort of the bivariate. There is an uncertainty in this risk that just because we don't know with the literature of aortic stenosis declining surgery, so we have to be able to communicate uncertainty, and there's quite a bit of work there to show that it's not something to shy away from. It's important to sort of say that there is a bit of lack of clarity in the literature, and to communicate that in a particular way. So this was one that was suggested, and we've used it in a way that's readily understandable to patients and their families. So this initial work, the qualitative work and the development and sort of reiterative approach towards refining the decision aid, including the frailty designation into our models and establishing sort of a first draft of a decision aid, then was a hypothesis generating approach towards developing a study, a pre-post study, to look at measures of comprehension and decisional quality, and to see if a formalized shared decision-making approach with these individualized decision aids had some discernible impact compared to a group that was looking at baseline consent, so sort of the status quo, and then introducing this new varied formalized SDM approach. So our study type here was a mixed methods pre-post design. The inclusion criteria was those 65 and older with isolated valve, isolated coronary artery bypass graft or cabbage plus valve, and we excluded urgent or emergent procedures. I won't speak at length with the questionnaires, but ultimately we included what was a modification of one of those previous studies, the Mishra comprehension scale. This was developing a set of questions that looked at really asking key pointed questions to each of the issues that would have been addressed in the consultation with the surgeon. The decisional conflict scale, which is a measure, a well-validated measure of decisional conflict, the SDM questionnaire, which evaluates the quality of the decision process between surgeon and patient. And then we wanted to see if this process influenced anxiety and depression, and also included the HADS and a qualitative exit interview. So our pre-intervention group, as I said, there was no change in standard of care to act as the baseline. Prior to surgery, all patients completed the MHCCS, the DCS, the SDM-Q9, and HADS, and prior discharge included the qualitative exit interview. Prior to the post-intervention, the actual interventional step here was introducing research staff and the designated decision coach and our surgeons into a formalized shared decision-making training sessions. And I'll note those briefly in the next slide. Our intervention group was presented with a decision aid. So these were 97 patients that were presented with those individualized decision aids following cardiac cath, personal profile, and comorbidity status. And they met with a decision coach to focus on the educational components in the decision aid. And similarly to our pre-intervention, they completed the MHCCS, the DCS, and the other questionnaires and a qualitative exit interview. So this is a little bit of what the training looked like. I won't spend much time on that, but ultimately a 90-minute online training course for research staff and the decisional coach by what I believe now is a HealthWise group, and used to be back in a few years ago was the Informed Medical Decisions Foundation in Boston. We included teach back and testing for all surgeons and a follow-up phone call with the IMDF. And below there's just a indicator of some of the core messages that were included in the shared decision-making training. This gives us a sense of the clinical characteristics of pre-intervention groups, so there weren't too many differences there in terms of, I think a little bit in the elective status, but otherwise these were relatively comparable groups. And our results showed pretty well across the board. Comprehension increased significantly. Decisional quality, this was after the decisional aid and decision coach were introduced and the training was introduced. Decisional quality improved. Decisional conflict had reduced, and anxiety and depression had not changed significantly. So what we got a sense was that formalized shared decision-making with personalized decision aids based on risk models that take frailty into account had improved comprehension, decision quality without increasing anxiety or depression. So there are some limitations with this previous work using the Katz Lee predictor model for frailty. We know that it's a relatively crude measure and it is unidimensional. It's looking primarily at activities of daily living. And this predictive model, while the first risk predictor, cardiac surgery risk predictor to frailty into account, has limitations. It models mortality, I believe, ineffectively, and discharge to an institution is a surrogate outcome for ultimate independence. So despite the positive effects that we experience with shared decision-making with individualized decision aids, uptake in routine practice remains relatively limited. So we are extending this work into implementation science and KT to really determine, even though we know it works, how do you sort of get it, how do you change behavior, how do you make this a routine care issue. So I'll pass it off to Dr. Hirsch to speak to some of the frailty measures that are out there, and then what comes into our CFN-funded study looking at a particular frailty measure in the study that we did to evaluate that.
Thanks, Ryan. So I'll move a little quickly here, just conscious of time. There's multiple frailty measures out there, and we were excited to try a locally produced and validated in a study in the nephrology patients tool called the FACT, which is multidimensional and can be filled out largely by the patient and their family member slash accompanying person who knows them well, which really takes advantage of the fact that, you know, specialists have no time, but patients have a lot of time as they wait around for specialists. You know, the Clinical Frail Scale is the sort of diamond level entry here. It's a very simple pictogram, but it's really based on a comprehensive geriatric assessment, which is beyond the scope of a specialist like a heart surgeon, and is based in its purest form on a 70+ item inventory. Is just not going to happen in a busy clinical practice. EuroScore II is a mortality predictor that doesn't take frailty into account, but is used across the world with a high degree of prevalence. The other is the Society of Thoracic Surgeons risk predictor model, although those are proprietary, so you can't get a hold of the coefficients. And this is just a pictogram of the EuroScore variables. It's a parsimonious model, so it's just a little over a dozen factors that will predict outcome. The fact that frailty assessment and care planning tool was developed by Drs. Mallory and Morehouse in geriatrics here, just building on the work of their colleague Ken Rockwood. It's easily administered, and there's a bit of an intervention required around a very mini cognitive approach. We already were the first to use frailty in a risk predictor in cardiac surgery with the Lee paper using Katz, and we're very keen to get some experience now with a more sensitive model. Remember that Katz was driving about at a level about 15% of patients referred for cardiac surgery, and we thought a more sensitive tool would be interesting to look at. One of the fun things about the FACT, a fun fact about the FACT, is that it's multidimensional and has a cognitive function mostly based on memory, has a daily tasks not dissimilar to Katz, has a social functioning inquiry and a mobility inquiry, and renders a score. And this is the cognitive assessment. It's just the memory with the distraction, Apple Penny watch, and repeat, as well as the clock drawing task. So the research question here, which was the CFN work and supported our master's student, Emma Wilson Pease, in patients over 65 undergoing elective cardiac surgery, meaning non-emergent, does frailty as measured by the FACT help predict outcomes? We're doing this in 2 centers, so we're maritime-wide, the New Brunswick Heart Center and ourselves. And then furthermore, in work that's not quite ready for harvest, in the midst of harvest, our 6-month outcomes from those patients. Are you home and independent, and do you have decisional regret? Our geriatrics colleagues tell us that if you already have some frailty, the likelihood that you're going to get better from intervention would peak around 6 months, and after 6 months, frailty will continue to exert its natural deteriorating force on the patient. So that's how we landed on 6 months. And this is just a schematic of the timing, which I won't deal with. And again, it's much like the last study, isolated CABG, isolated aortic valve replacement, or a combination of the two. Heart surgeons are simple folks. We only do a handful of operations. And we're looking at in-hospital mortality, major adverse cardiac events, defined in this study as a deep sternal wound infection, or permanent stroke, renal failure, or prolonged postoperative stay, and septicemia, all are very problematic for patients. And at 6 months, ultimate disposition, some health-related quality of life, and decisional regret. The results, the baseline characteristics for the preoperative patient characteristics were similar. Patient and surgeon case mix didn't have an effect, but very interesting. Of the 230 patients, this is a partial analysis, something I usually shy away from, but dear Emma needed her master's. So I turned a blind eye and let her do some analysis arm's length from us. We'll ultimately have 450 patients to look at out to 6 months. But a brief look showed that almost 90% in the over 65 group demonstrate at least vulnerability level 4 frailty in one of the domains. This maybe isn't as shocking as it seems, and this is just the actual data split out. We see that 63% are frail at level 4 in terms of mobility, but a lot of these patients have critical coronary disease and critical aortic stenosis, so their mobility will logically be limited. Similarly, social function, daily tasks, and memory have significant prevalence at this age group among non-emergent patients going for surgery. In terms of the impact of those measures in an unadjusted look, social function, daily task, and memory all predicted both major adverse cardiac events and major adverse cardiac events with mortality. And we look at adjusted results, and here, for the purpose of this master's student, does it improve and refine the predictive measure of EuroScore II? Again, we see that mobility does not, but social, daily tasks, and memory functions all do predict bad things, and I believe the next slide, improve the model statistics over EuroScore II, so as an improvement in terms of risk prediction. So it's logical for us now to take these coefficients and build a new decision aid, an individualized decision aid, which is peculiar to the work that we're doing, that it's much about a particular patient's risks, depicted with those dot plot pictograms so that it's comprehensible. So what we've shown you is that more sensitive measures the fact of frailty are predictive of adverse outcomes, that it operates in a domain-specific fashion, and we'll know that more robustly with the 450 patients in, but it seems as though mobility is going to be a relatively soft, if perhaps a non-predictor, and frailty provides better risk prediction than EuroScore alone. It's certainly more sensitive and more specific than Katz, and our plan is to incorporate it into our SDM predictions. Our next steps are to complete the 6-month follow-up on the 450 patients and finalize some data on independent function, decisional regret, and health-related quality of life. A brief peek, arm's length from us, at the decisional regret data would show that about 25% of patients over 65 at 6 months regret the decision for cardiac surgery. So there's clearly work to be done to improve comprehension and match expectations of an intervention to what we're able to actually accomplish for patients. We may be able to create domain-specific risk predictors for independent function at 6 months, which is where the money is. It's a much better outcome than you got discharged to an institution. I really don't care if I get discharged to an institution, if I get home ultimately and I'm okay. But if I'm not okay at 6 months, I want somebody to put a number on that. And we're now about trying to secure some funding to do some implementation science approaches to establish SDM in the process of care, because it's a big and busy process of care, and it's hard to get people to do something just because it makes sense to do, if you will. We have lots of folks to thank, but I'm cognizant of the time, so I'll just thank CFN and open it up for any discussion.
Great, thank you very much. Very good talk, and I think we have some questions rolling in, but we'll get it started here with the first question, and that is, how does changing the definition of frailty to include subtler degrees of frailty benefit cardiac surgery patients?
So I think I was concerned, I'm not sure it does, but I was concerned, and we were concerned as a team, that the Katz data, a score of 1 out of a possible 8, hammered the result with an odds ratio of 2 for mortality, odds ratio of 6 for discharge to institution. So I thought to myself, geez, we better get a more subtle measure to be able to get a better picture of who's at risk for an adverse outcome. I'll talk a little more. When cardiac surgery was invented, it was really dangerous. Then it got pretty safe through the efforts of these risk predictor algorithms, and I think cardiac surgery has taken the lead on measuring outcomes. You get your mortality down. There's no equipoise between symptomatic aortic stenosis and having an aortic valve replacement or not, because you're going to die in 3 years. But once you're frail, that's not true anymore. You're going to die in 3 years, but you've got 3 years to live that might be pretty good versus lose your independence, which is worse than death. So in an older population that has a degree of frailty, I think it was very important for us to suss out what's going on with lesser degrees of frailty, and Katz is just a very cruel tool. Like, Katz is something you can see across the hall. It's actually shocking to me. And bear in mind, cardiac surgeons don't generate their practice, unlike almost any other surgical group. They're referred to us by our cardiology and internal medicine specialists who are at a loss for what to do with the symptomatic patient and send them along to us, also under the presupposition that there was no equipoise before, there must be no equipoise now. And I think we're all about demonstrating where is the equipoise. I think you should do shared decision-making everywhere, but you probably only need to do a meticulous, careful job in the places where there's a lot of equipoise. I don't think we need an elaborate shared decision-making model for acute appendicitis in 19-year-old men, because, you know, it's really much safer to have an appendectomy. But it's not clearly in line with your goal to have an aortic valve replacement when you have a degree of frailty and a real risk of loss of independence, and you're functioning okay, even though your risk of mortality is high without surgery, because your risk of loss of independence is high with surgery. That's a long answer to a short question.
No problem. Thank you. That it is a unique population. And so when we think about common barriers to achieving that shared decision making in cardiac surgery patients, what are those barriers?
Yeah, I think there's quite a few. And as Dr. Hirsch alluded to, the reality of the time-sensitive, busy realm and reality of cardiac surgery is such that there are a number that just have to be acknowledged, and I think there's still a realm in which there's a response to each of them. I know for our groups, time is always the issue, right? It's always this, there's never enough time, and as we heard in the focus groups, independent of what we do to try and improve the decision process, if there's not enough time to actually, you know, move things upstream, to actually have the time to consider the information that's provided individualized, then there's only so much sort of effect that can be done there. So our next steps when it comes to responding to that barrier is putting this online as best we can with our IT colleagues and developing online decision aids where at the moment of cardiac cath or immediately following, we can then sort of present this work in a way that starts that communication, starts that process, as opposed to waiting for maybe that referral down the road 48 hours prior to the surgery. So one of those barriers of time absolutely needs to be addressed.
And another is, I think, a culture, especially in highly specialized medical circles like cardiology, cardiac surgery, of expectations of a paternalistic approach. I can't tell you how many times people say, you're the expert. I'm going, yeah, let me just walk you back to, I don't know who you are, and I don't know what your life is like. You actually have a lot of expertise I don't have about you. And let's try and make this decision together and still the resistance, say, well, what should I do? And I don't know how you change that culture, but I think getting, as Ryan says, the data to them earlier, and that, you know, the pages that we showed you of that decision aid have activation statements in them going, you know, your voice matters, you're an expert here, make sure you're making a decision that fits with your values. Yeah.
Great. Yeah, those are good points. And in that mixed method study that you did, the interviews with the patients, were there also interviews with the decision coaches or surgeons to find out sort of how they perceived the decision-making training, the acceptability of the tool? Was there any feedback from them qualitatively?
Absolutely. So I'm not sure if that's included in the little, somewhat less deep dive of the two slides that I had, but the surgeon group particularly was interesting because we weren't, put 8 cardiac surgeons in a room together and who knows really what you're going to get, but I think that was one of the power of the qualitative work at the beginning, because we actually got quite a good confirmation from them that this development of decision aids, it's sort of a cost to them as well when patients are not as well informed or when the expectations don't meet up with reality. So some more considered approach is something they all signed on for, and it's how do you make that work, and how you kind of get the champions to encourage it. I mean, I think that's a whole other set of issues, but I think philosophically the idea that, and I think that was the goal of the qualitative work in some regards, was would people be interested in shifting the consent process a little bit to include a more preference-sensitive acknowledgement, especially with this frail, vulnerable group. And we heard quite clearly from them. The other group that was important to hear from were the nurses, both from the IMCU and the ICU, who particularly had that, and typically it seems as though nurses are quite often the patient advocates, and most vocally the patient advocates, and they said as well, you know, the lived experience of someone going in with unrealistic expectations or maybe not matched expectations, and then for one going through a process that was relatively non-complex or non-complicated, and then the alternative of someone with, you know, in the ICU for, or in the hospital for 40 days or 50 days or longer, that there really needs to be a clarification of those expectations. So we were heartened, I think, by the response we got from it, and it speaks to doing that qualitative work first, maybe sets up for a better approach to identify implementation science work and KT work down the road.
Yeah, absolutely. I mean, that's an important component of the uptake of the tool. So another question here is about what can caregivers and patients do right now to help them with their decision making? So how do they give themselves as much time as possible, you know, given that their life might change significantly afterward?
Yeah, so it's a challenge, and I think it's just a culture change that's hard to bring about. But this idea, I mean, shared decision making is broadly endorsed but rarely practiced, I think. And so anybody in that role, generalist or specialist, would do well to activate the patient to go learn. The internet's available. If you're on the Upper East Side of New York City dealing with the top two deciles of socioeconomic status, you have no worries about the fact that they're going to come in very prepared to let you know what their preferences are. But we've got to reach out to the rest of the folks to get them active. They've done their University of Google, but we've got the rest of the group. We need to. It's our responsibility to get them educated well, but we can really, even at this moment, get patients activated to learn what they can and to formulate and write down the questions they have about the impact this has really in the areas where they're expert. I'm going to know durability of angioplasty versus coronary bypass surgery and how medical therapy will work and what it might look like statistically, and they can rely on me for that. They can double check me, and that would be healthy. But their questions might more center on what will this mean to my return to work? What risk do I have of not returning to work? And you know, this doesn't just work in the frail and the elderly. If you're looking at percutaneous coronary interventions, angioplasties versus coronary bypass surgery has longer durability. So of course, younger patients would always opt for that, but that's a paternalistic error because some young patients may not have insurance, are the primary caregiver and breadwinner for the family, and can't wait for EI benefits. And if they get an angioplasty, they're back to work in a week, and they may quite legitimately opt for that, even though we're a little concerned that they didn't pick the most durable intervention. So there's lots of room for patient preference, and I think so. The answer to the question is just encourage patients to own that responsibility they have to their families and to themselves, to not end up with decisional regret 6 months later because they just took someone else's word who doesn't know a thing about their life.
Right. And in terms of, as a surgeon yourself, are there places that you would recommend a patient or caregiver go look? Like, I mean, I guess everyone can Google, but as you know, be interactive.
A very dangerous recommendation, of course. And I think what they can really do is just very clearly question their experts about what they need to know and to frame their questions about the impact on their own lives. And of course, we're trying to build decision aids that would fill that gap. And we think we have one. And the question is, you know, how to get it delivered and made and not add any cost to the system, right?
Right. And just another comment here, whether or not you've had any feedback with your decision aid, just because you have both red and green little dots.
We have.
For your colorblind
and we have developed alternative models. We have managed to select the highest prevalence of color blindness in males, and so the next iteration will be better. But we do have a shape version that can be used in the colorblind population.
Yeah.
Okay, and I don't have any other questions, but before we wrap up, maybe Dr. Hirsch or Ryan, do you want to have any closing comments you want the audience to leave with today?
I'll just pitch a note of deep gratitude to CFN and to other funding groups like MyTax that creates the possibility. You know, here in Nova Scotia, we have among the second highest prevalence of cardiovascular disease and cardiovascular death rate. And to be able to do this research, and we have a relatively aged population, to be able to do this research in Nova Scotia, and most gratifyingly to be able to train Emma and Ryan, who are going on to be scientists potentially in our own region, to build that capacity that's going to improve the care here, is probably the most exciting part of my own professional life.
Well, that's great to hear. So I think we'll close a little early today, give you all an extra 7-8 minutes. But before you leave, just wanted to remind you that there is a post-webinar survey that will pop up on your screen. And if you have any questions about the presentation or comments, Ryan's email address is listed there. And finally, just that our next webinar is on Thursday, February 28th. So we'll hopefully join us then. Have a great day, everyone.